There are a number of different types of spontaneous abortions and or classes, however you want to call it. So I'm just going to go through these and talk about them. So the first one we're talking about here is called a complete spontaneous abortion. And this one, you know that you've had one, or the sign of symptom that you had one is because you will have essentially pass all of the products of conception. It's basically the growing baby will come out, and you'll see the whole thing there. And after it comes out, the pain that you had from pushing it out will stop. The contractions will stop, but you may still have some spotting afterwards. That's normal. So you can diagnose this because the ultrasound will show an empty uterus, and then you'll know that you've passed everything. And there's really no treatment for this, so this is called complete. The next kind is called incomplete. Okay, so in this one, you'll pass some products of conception. There'll be some bleeding, some cramping, and when you look, you'll see some visible tissue on exam. However, not everything came out, and so the cervical os, okay, that little cervix, little hole there, it will be still open. Okay, now in the complete, the cervical os was closed because it did its job and it closed up. In this one, it recognizes the job's not done, and so it's still open. So the ultrasound will show some retained fetal tissue, and you may need to do a manual uterine aspiration, or you may have to do a D&C, dilation and curettage. Okay, so somehow you're going to need to get that stuff out of there. The products of conception. Sorry, that sounded disrespectful. Next is threatened. So threatened spontaneous abortion. This is where no products of conception are expelled. Okay, so the parts of the baby have come out, and there is uterine bleeding, and there may or may not be some abdominal pain, like cramping. The cervical os is closed. Okay, it's not open. The membranes are intact, and there is fetal cardiac motion on ultrasound, which means the baby's alive. Basically, there's bleeding. Okay, there's bleeding when you don't want there to be bleeding. What is the treatment? Pelvic rest. In other words, no intercourse, no running around, don't move your pelvis, don't do anything that could aggravate anything, and try that for at least 24 to 48 hours, and then follow up with an ultrasound to assess the viability of the fetus conception. Okay. Then there's the inevitable spontaneous abortion. In this one, nothing's been expelled yet, but there's lots of uterine bleeding and there's cramps, and when you look at the cervical os, it's open, and there may or may not be a ruptured membranes as well. And for this one, you're going to need to do the manual uterine aspiration, or maybe a D&C. Maybe you can use misoprostol, or maybe some sort of expectant management to see what happens. Maybe mom will push it out on its own. Next is called a missed spontaneous abortion. And this one, no products of conception are expelled. There's no fetal cardiac motion, no uterine bleeding, but there is some brownish vaginal discharge. You look at the cervical os and it's closed. There's no fetal cardiac activity, and the retained fetal tissue is found on ultrasound. You may need to do the manual uterine aspiration, D&C, or maybe some misoprostol. Next is a septic spontaneous abortion. This is endometritis leading to septicemia. Maternal mortality is 10 to 15%, which means the mom can die 1 in 10 times, about 1 in 10, 1 in 9 times, somewhere in there. You'll find hypotension, which means like really low blood pressure, hypothermia, which means the temperature is low, and increased white blood cell count. You may need to do manual uterine aspiration, dilation, curettage, and some IV antibiotics. Next is intrauterine fetal demise. Okay, so for this one, there's an absence of fetal cardiac activity. That's what you find. You find the baby's not, its heart is not pumping. Uterus is small for gestational age, or there's no fetal heart tones or movement on the ultrasound. So what do you need to do? You need to induce labor. So you need to evacuate the uterus, D and E, dilation and E, whatever that stands for, to prevent DIC at gestational age greater than 16 weeks. So basically, if it's greater than 16 weeks, then they're going to have to pass the baby. Okay. And then lastly, there's a recurrent spontaneous abortions is if in early pregnancy, often due to chromosomal abnormalities. So if it happens early on, you're thinking chromosome problems, like first trimester stuff. If it's later in pregnancy, that it can be to some problems like maybe hypercoagulable state. So maybe like the blood is coagulating and not allowing enough blood to get to the baby. Could be systemic lupus erythematosus, could be factor V Leiden, could be protein S deficiency, could be an incompetent cervix, which means they would just open up and let out the baby. This should be suspected with a history of painless dilation of the cervix and delivery of a normal fetus between 18 and 32 weeks. Ooh, that'd be really sad. What do you do for this one? You need to do some karyotyping for the parents to find out if they've got some sort of genetic issue. Do a hypercoagulability workup for the mother and evaluate uterine abnormalities. Treatment is going to be may need to suture the cervix closed until labor or until the rupture of membranes occurs with subsequent removal prior to delivery. May need to restrict activities. So that's kind of an overview of spontaneous abortions.